Hello, my name is Richard Stone. I'm at the Dana-Farber Cancer Institute in Boston, Massachusetts, and I'm pleased to talk to our wonderful patients about acute leukemia, myelodysplastic syndrome, and CML. Here are my disclosures of folks I've been involved with a little bit during the past 3 years. So what is leukemia? Leukemia is an overabundance of white blood cells in the peripheral blood. If they're immature, like stem cells, without defining features of functional cells, we call that acute leukemia. And if these cells are mature and they look like normal cells, we call it chronic leukemia. We're going to be talking about most of these entities here. The acute leukemias are really two main varieties: acute myeloid leukemia, cells that are destined to become neutrophils or infection-fighting cells, or ALL, acute lymphoblastic leukemia. These are cells that are destined to become lymphoid-type cells, or cells that make antibodies or direct the immune system. And in the chronic myeloid leukemia, these are already adult myeloid cells. In chronic lymphocytic leukemia, which we won't be talking about today, it's cells that are mature lymphocytes. MDS, which we will touch on a little bit, are cells that are myeloid, but are not really making the mature ones that we need. And in myeloproliferative neoplasms like CML, which we will talk about, they're making too many of normal cells. So here's a schematic of how blood cell development occurs. We start out here on the left side, or in the middle, I guess, with these stem cells that have the ability to mature, depending on the right signals, into cells that make either our red cells, which carry oxygen, our platelets, which prevent bleeding, or our white cells of these various types, which prevent infection. And there are a bunch of different types of white cells. Your T and B cells, your basophils, your eosinophils, and neutrophils, which are a key type of cell that prevents infections from bacteria and fungi that live with us all the time. So this is how it works. We have a maturation process. If there's a block in this maturation, we get leukemia, immature leukemia, acute leukemia. If there's an overabundance of, let's say, neutrophils, we call that CML. This is another way to look at the different types of myeloid malignancies. This does not include ALL, but if you have a low blood counts, basically it might be MDS. If you've got too many immature cells, you get AML. If you've got a high red count, you might have polycythemia vera, which we're not going to talk about today. And if you've got an overlap between too many cells in the bone marrow and too few cells in the blood, that might be myelodysplasia. So we'll talk about all these things in more detail over the coming 15 or 20 minutes. So let's start with AML. That's the disease that is the most deadly of all the ones I'm going to be talking about today, but it can be cured, which is nice to know. It's an unbridled proliferation of hematopoietic stem cells that result in marrow failure and patient death unless we're successfully treated. Now we can successfully treat a lot of patients with AML today. The risk factors for getting AML are age. It's more common in older adults. The median age is about 70. Believe it or not, prior chemotherapy for other cancers can lead to AML, which is not something we like to see, but is a known complication of treatment of other types of cancers like breast cancer sometimes. Ionizing radiation, which is given for therapeutic reasons, or hopefully not, but for military reasons or industrial reasons. Industrial solvents like benzene are known to cause leukemia, sometimes petroleum distillates. This is why, historically, leukemia has been more common in men than women. There's about 15,000 new cases of AML in the U.S. annually. We now recognize that a higher proportion than we once thought have a hereditary predisposition to AML, although that's still relatively unusual. When we see too many immature cells in the blood or marrow, we say, is it AML, which we treat in a certain way, or is it ALL, which we treat in a different way? And we have a lot of different ways to figure this out. We can look at under the microscope. We do special, we call stains or cytochemical stains to look for whether they have more myeloid like neutrophils or more lymphoid like B or T cells features. We can do this with under the light microscope, or we can ask, what the surface characteristics of the cells are by asking what proteins are expressed on the surface. Just like we have our own phenotypic characteristics. You can recognize me from another individual. You can recognize an AML cell from an ALL cell by virtue of what proteins, which we have these numbers that designate what proteins they might be on the surface of the cell. So we can find proteins that are typical of myeloid derivation, and that would be an AML cell, or proteins which are more typical of lymphoid derivation, which would be an ALL cell. And that's what we do when we first see somebody with acute leukemia. We see these immature cells in the blood or marrow. We say, oh, is it AML or ALL? We have to know that. Also, when someone presents with acute leukemia, they have a block in differentiation. So they have too many immature white cells. And when that happens, you don't make enough normal bone marrow production cells, which would be neutrophils, which fight infection, platelets, which prevent bleeding, and red cells, which prevent you from being fatigued because they carry oxygen. So if you have leukemia, you generally have bone marrow failure. You could have infection or fever from neutropenia, fatigue from the anemia, or bleeding from the low platelets or thrombocytopenia. Also, there's some chemical constituents of the blood that get disturbed when you have acute leukemia. The platelet count can go down or the platelet count can go up, and you can have other abnormalities, which the doctors will pay a lot of attention to when you come in. And sometimes there's so many white cells, they're breaking down so much, they cause what's called tumor lysis syndrome, where you have an overabundance of the chemical constituents of those cells that are in the blood now, not packaged up into the cells as the cells are dying, and that can cause some problems. Now, AML, this disease of immature myeloid cells, is not one disease, really. Unfortunately, it's a rare disease or not a common disease. But even though it's not common, we can break it up even further into different subcategories. This is a Kaplan-Meier curve, and you'd rather be on the top than on the bottom because that means you're living a long time. Certain subtypes of AML, characterized by either the genetic abnormalities we see or the chromosomal abnormalities, have either a good or bad prognosis. So once we figure out whether it's AML or ALL, if it's AML, we start to ask, is it a good prognosis disease or a bad prognosis disease? Because that might determine how we treat it, and particularly whether we'll do a stem cell transplant, which we need to do for the bad prognosis guys, and maybe not a stem cell transplant after the patient goes after initial therapy for the good prognosis guys. So we want to make sure see if they have an infection from bone marrow failure, give them platelets if they have a low platelet count, and be careful to fix whatever metabolic abnormalities the patient may have due to the overabundance of leukemia cells. And then we have to treat the patient. We want to cure them. We want to eradicate every last leukemic cell in the body so you don't have to deal with it for the rest of your life. You'll not be subject to bone marrow failure and major problems from lack of neutrophils, platelets, or red cells. So the first thing we do is we give chemotherapy called induction chemotherapy. We have about 10 to the 12th leukemic cells at the time of diagnosis. We can kill off 3 logs or 99.9%, and we're in remission. We see less than 5% blasts in the marrow, which is normal, a normal blood count. We even have novel techniques to look for even finer degrees of remission, if you will, MRD negative remissions. And the second goal is to get rid of those residual 10 to the 9th or 10 to the 10th cells where you can still have a lot of leukemia, but you can't see it under the microscope. You might be able to find it by other means, but you can't see it under the microscope. So we want to give some therapy after the initial therapy. It takes about a month, 7 weeks, 7 days of therapy, wait a month, have a normal blood count. Then marrow looks good, but you need more therapy to prevent those residual undetectable cells from coming back and creating problems. So there's a special type of AML that is about 10% of all AML that's treated completely differently from run-of-the-mill AML. It's called APL. It's a disease that used to kill people routinely, but now we can save 100% virtually of people that have it by using not chemotherapy with arsenic trioxide given intravenously, soon hopefully orally, and retinoic acid, which is a vitamin A analog, which can be given orally. So we have this rare subtype of acute leukemia that's eminently treatable without the kind of chemotherapy you've heard about that can make you sick. The arsenic and retinoic acid have their own set of side effects, but you don't lose your hair, you don't become nauseated. So for the other 90% of AML patients, we sort of divide the therapy up according to age. And by arbitrary means, we divide people into those that are under age 60 and those that are over age 60. For over age 60, we're basically using, and this may change in the near future, but we're basically using chemotherapy that lands you in the hospital for a whole month. It takes about a week to give most of these chemo regimens. And then you're waiting to recover your blood counts because these chemo regimens make your blood counts low. And once you achieve remission, as I said, we have to give additional therapy to clean up the residual leukemia cells. And that we usually use either high-dose chemotherapy or a stem cell transplant. So there are a bunch of people now that we don't think can tolerate that type of intensive chemotherapy that I just mentioned. And currently unfit for standard chemo AML are people that are 75 or greater or have significant comorbid disease. We also have a new tool called geriatric assessment, which can give us, like, ask the patient to get up and walk for a few feet. That'll tell us how able they are to tolerate chemotherapy. And if you're older and or you're not fit, we have some other good options beside the intensive chemotherapy that I mentioned a second ago. We have what's called HMA venetoclax or Ara-C venetoclax. HMA means a week of easy chemotherapy plus 2 or 4 weeks of pills called venetoclax, and that can lead to a pretty good outcome these days. Some of our older patients, up to age 75, may still be a candidate for a special type of transplant called a reduced intensity transplant. So we have lots of options, even for patients that until recently did not have many options. We have a new type of chemotherapy called CPX-351, which is a fat emulsion of the standard chemo drugs. This seems to work a bit better than regular chemo. We also have this drug that I've been referring to called venetoclax, which helps to make holes in the mitochondrial membrane and thereby make standard chemotherapy more effective. So we have a lot of new tools we can use for these less than young patients. And this just shows us that if we combine azacitidine and venetoclax, we do better than single agent azacitidine alone. And this is the new standard of care for our older patients with AML. If you, God forbid, go through initial therapy and then relapse, we have a bunch of options even there. And the goal after you relapse with AML is to get you into a second remission, then do a transplant. We also have targeted therapy with IDH inhibitors, which block an enzyme that's mutated in about 10% of AML. We also have FLT3 inhibitors, which block an enzyme that's mutated in about 30% of AMLs. This is a trial in relapsed AML, but it also works in the upfront setting, as I already mentioned. And one thing hot off the presses, based on work done by my colleague Scott Armstrong at Dana-Farber, we have a new drug called a menin inhibitor, which worked great in mice and actually worked very well in people with a specific subtype of AML. So we're very excited about this. Again, it's a non-chemotherapy approach where we're really realizing our goal of treating people based on their own particular type of leukemia with their own particular molecular lesion. So let's spend a few minutes on ALL, a less common disease in adults, but this is the one that is the poster child for childhood cancer. Thankfully, children don't get cancer very often, but when they do, they often get ALL. And when they get ALL, they have a 87% chance to be cured. Obviously not 100%, but it's much more curable than adults with the same disease. But we've learned that we can use pediatric-inspired regimens for our younger adults. We can add a drug called imatinib or Gleevec, which I'll talk more about in our Philadelphia positive ALL types of patients. So, and we have 4 new drugs in the past few years. One is an antibody drug conjugate called inotuzumab, which binds to a specific place on the ALL cell, but then injects a warhead. We have a medicine, which is a bispecific antibody, which takes a T cell, your own T cell, and brings it to bear to kill your own leukemia cell. And we have 2 CAR T cells, which you probably read about in the paper, which is a living therapy that works in ALL pretty well, where we teach our own T cells how to recognize the leukemic cells. It's an amazing advance. As I said, we can now use pediatric therapy in adults. We've gotten better supportive care, and we've made big strides in treating adults with ALL. And even in advanced patients, the CAR T cells have a very fascinating, good track record. So we've made strides in ALL using, in the Philadelphia positive ones, we use a pill plus chemo. And actually, we've gotten away from chemo altogether, more or less. We use the pill plus some steroids plus the blinatumomab, and we get remissions that might not even require a stem cell transplant. So we have a lot of excitement in ALL. Moving on to myelodysplastic syndromes, which are a heterogeneous group of bone marrow failure syndromes characterized by hypercellular bone marrows with the dysplastic cells and peripheral blood cytopenias. This is an example of what's called a ring sideroblast, where you have iron-laden macrophages surrounding the nucleus of a cell. And this is now again a new therapy that we can give to these people. By and large, therapy is risk-adjusted. We use supportive care for lower-risk patients and low-dose chemo for higher-risk patients with MDS. We have brand new prognostic systems, which are great, using the molecular features in a given patient's MDS. We can assign patients from low-risk disease over here to high-risk disease over here. These folks get chemotherapy. These folks get supportive care. We have new therapies for our low-risk patients, including luspatercept, which binds to evil humors and allows the red cells to get made. We have imetelstat, which is not yet approved, but will be during the year, I think, which inhibits an important enzyme called telomerase. So we have a lot of exciting new things, both in lower risk and in higher risk. We may be adding venetoclax to azacitidine to affect good outcomes. Again, azacitidine, venetoclax is not approved, but azacitidine to be given with azacitidine in MDS, but it probably will be pretty soon. So in MDS, for the lower risk, we have lots of options: transfusions, growth factors, luspatercept, eventually imetelstat. For the higher risk, we have our azacitidine or decitabines, maybe with venetoclax in the future. So in the last few minutes, I want to talk about one more disease called CML. And this is one where we've made incredible strides in the last 20 years. Right now, when I was a fellow about 30 years ago, we used to transplant all the patients we could because that was the only way to cure the disease. Now we just give people a pill, and for the most part, that's all they need. Sometimes they can even stop the pill. So CML is caused by this Philadelphia chromosome described in 1964 in Philadelphia, which causes a 922 chromosomal translocation, which causes a fusion protein called BCR-ABL, and that drives the production of white cells, which can cause problems down the road. But my friend Brian Druker, who was a fellow right here at Dana-Farber with me in the 1980s, helped to develop this drug called imatinib or Gleevec. It's been transformative. Hardly anybody dies of CML anymore. But there's a bit of an art form to using the drug we have in CML. Imatinib Gleevec was the first one. We now have 4 different ones that can be used initially, and another couple that we can use if the patient fails upfront imatinib or one of the cousin drugs. We have this brand new one called asciminib, works a different way from the other 5. It's a really neat mechanism, not that you care about that, but it is a neat mechanism and may therefore be able to be used when the other ones don't work. Now, these things are pills, but they're not free of side effects. So it's important for you and your doctor to recognize what the side effects might be and deal with them. Usually these are side effects that are tolerable, but once in a while they're not. And in those cases, we need to switch drug. We know that these low-grade toxicities that sometimes people have to put up with are important because they're taking these drugs for a long period of time, and we need to talk to our doctors about that very carefully. We also have to be sure the drugs are working, and we have this yellow, red, and green type of scenario where we know after a certain period of time on the drug, your level of CML should be certainly low by a certain amount. And we have blood tests that can tell us this. So you don't need marrows very often in CML. We can actually stop TKIs, stop these drugs if you're doing really well. Why would we want to stop? Because you can get pregnant. It's better not to take medicines you don't need. It's cheaper, no toxicity, and we do help with cost. To stop the drug, you have to be doing really well for a long period of time. If we do stop it, you have about a 50% chance that it won't come back. So in conclusion, we talked about AML. Though we have responsive subtypes, it's intrinsically resistant. We often need to do a stem cell transplant. In ALL, we've made great strides recently by employing pediatric-like therapy for younger adults, by using the same drugs we're using in CML for the Philadelphia positive ALLs, by using blinatumomab to take care of to clean up residual amounts of leukemia left over after chemotherapy, by using CAR T cells, this living drug in advanced patients. In MDS, we have new tools to give you a more accurate prognosis. We have new therapies in lower risk disease, imetelstat and luspatercept, and possibly a new therapy in higher risk disease by adding venetoclax to azacitidine, as we did in AML. And finally, in CML, the tyrosine kinase inhibitors have brought a normal life expectancy. You can tell a patient who has CML, who walks in the door today, that they have the same natural history as one of their buddies does with out CML. We have a new option called asciminib, which works a different way and therefore can pick up some patients who are resistant to the more typical tyrosine kinase inhibitors. And you've got to know the toxicities of the various drugs that ought to help patients maximize their quality of life. So I've gone through almost all the diseases that I treat in a given day. It can be complicated. It took me 35 years to begin to understand these things. I don't expect you guys to be able to figure it all out in 20 minutes, but hopefully you've gotten some taste for what these diseases are like, how we think about them, how we use therapy in them. And I couldn't do this without a team. It certainly takes a village to do research and patient care in cancer medicine, and I have many people around the world to thank for doing that. I'd be happy to answer any questions via email or calling me, or if, God forbid, you or one of your relatives needs to get a second opinion, always happy to see patients with these entities, and hopefully you don't get it, but we do have a lot more we can do about these things now than we did a few years ago. And we're going to continue to make more strides thanks to your support and a great team around the world working on these things. So thank you very much for listening, and have a great day.